Good evening. Welcome to Second Opinion. Investigators provide perspective on the current and future use of novel therapies for non-Hodgkin lymphoma. I'm Dr. Brad Kahl, and I'll be moderating the meeting today. This is our faculty today. We have Dr. Christopher Flowers from MD Anderson, Dr. Sonali Smith from the University of Chicago, and Dr. Matt Lunning from the University of Nebraska. Presenting cases that we'll give second opinions on today will be Ann LaCase from Dana-Farber and Jill Saul from Memorial Sloan Kettering. Here are our faculty disclosures. And we want to obviously thank our commercial supporters for this program. So just a reminder, this educational activity contains discussion of some non-FDA approved uses of agents and regimens, and please refer to official prescribing information for each product for the approved indications. So here's our agenda. And without further ado, I'll turn it over to Dr. Flowers to talk about incorporation of CD79B targeted agents into lymphoma management.
Great. Well, thanks so much, Brad, and thanks so much to all of you for attending this program this evening, as opposed to some of the other options that you had next door, where the food was the same, but maybe more around solid tumors. And I'm going to talk about some of the data related to CD79B agents in diffuse large B-cell lymphoma, both in terms of the potential uses in the front line and in the second line. This agent, polatuzumab vedotin, is a CD79B antibody-drug conjugate that works importantly because when CD79B, the antibody, binds to the cell surface molecule, it gets internalized. And so as a result, brings into the lymphoma cells the antibody-drug conjugate vedotin, which is an MMAE inhibitor, MMAE microtubule inhibitor, and then leads to cell kill. And so that was tested first in the relapse setting, and I'll go through those data in just a little bit, but then ultimately moved to this frontline trial that you can see was published a few years ago from the primary results in the New England Journal of Medicine, looking at the combination of polatuzumab R-CHP, where there was a vincristine placebo given, compared to standard R-CHOP, where there was a polatuzumab placebo given in that. So this is a double-blind randomized controlled trial for patients 18 to 80 years old with an IPI 2 to 5 and ECOG performance status of 0 to 2 as their primary criteria. And I think the other thing to note is that there were 2 additional doses of rituximab given, in part because the groups in Europe commonly give 8 cycles as opposed to 6 cycles that we commonly give in the United States, with the primary endpoint being progression-free survival. And as you can see here, in terms of the safety summary, when you look at polatuzumab R-CHP versus R-CHOP, that there were very similar safety profiles, perhaps slightly more neuropathy in that group, and a little bit more neutropenia, but that did not translate into increased adverse events. And this was a well-tolerated regimen that allowed the distribution of full cycles of therapy and very limited numbers of dose reductions, with only less than 10% of patients on the R-CHP arm requiring a dose reduction of any study drug compared to 13% with R-CHOP. When you look at the primary endpoint for the study, as was published in the New England Journal of Medicine in 2022, the study met its primary endpoint with an improvement in progression-free survival of 27% in the relative risk with a hazard ratio of 0.73, with a 24-month progression-free survival of 76% in the polar R-CHP arm versus 70% in the R-CHOP arm. And I think it's important to note that when you look at R-CHOP arms in clinical practice and in prior trials, this R-CHOP arm actually performed better than R-CHOP had in the past. And then the most recent data are from these 5-year data that were just recently presented and published in the Journal of Clinical Oncology, demonstrating that there was continued benefit for the group that received Pola R-CHP, now with 5 years of follow-up with maintenance of the hazard ratio, as was seen in the original study. I think the other thing that was notable that's been described by this regimen is that when measured by gene expression profiling using nanostring, that the group that received the group that had activated B cell like subtype or ABC, shown in the curves to the left, had a marked difference in terms of progression-free survival for the group that got pola-R-CHP, but no difference was noted in the group that was GCB by gene expression profiling. There are not yet data published on the use of immunohistochemistry for or IHC for non-GCB and GCB, so these are really only based on gene expression data. And I think importantly, as we think about this moving forward, the ways that we're trying to address that, Dai Chihara from our institution at MD Anderson is using a gene expression profiling based assay where we have developed an RNA-seq based assay that we've shown that we can get a median turnaround time of approximately 10 days with that assay, and that it recapitulates the same ABC and GCB as described by nanostring, and are looking to utilize that as a way for being able to apply this in clinical practice in a clinical study moving forward. When we look at the original data for the use of polatuzumab vedotin that occurs in the relapse setting, and that was based on these data, where there was an overall survival benefit for the group in the randomized phase 2, showing pola-BR in the blue curves had a benefit over bendamustine rituximab in the relapse setting. And so as a result, that regimen has been followed up with an extension cohort with an additional 100 patients shown to the right that has similar progression-free survival, and then additional follow-up of that randomized study showing that those survival benefits, both in terms of progression-free survival and overall survival, persist over time, with a median overall survival on the pola-BR arm of 12 months. That is also been described here with this safety summary for the adverse events seen in the group. And I'll turn your attention to the right side of the slide with the pooled data for pola-BR for both the randomized portion and the additional 100 patients in the extension cohort, where the major adverse events were neutropenia that occurred in 47% of patients, with about a third of those being grade 3-4 AEs, and infections occurring in almost 50% of patients, but only 21 or 22% of those being grade 3-4 AEs. I think important to note is that the peripheral neuropathy that occurs with polatuzumab typically occurs after 6 cycles, and in this regimen where only 6 cycles were given, the grade 3-4 neuropathy was seen only in 2% of patients. The other studies that are now reading out are these randomized data looking at the combination of mosunetuzumab and polatuzumab, or the SUNMO trial, where it was compared to rituximab, gemcitabine, and oxaliplatin in a randomized fashion, where you can see an improvement in the overall response rate in the relapse setting for diffuse large B-cell lymphoma, shown for mosun pola at the left, where there was 2-to-1 randomization with 138 patients enrolled in the mosun pola arm, with an overall response rate of 70% versus 40% seen in the R-GemOx arm shown here. I think important to note that the primary endpoint for this study was progression-free survival as well, and that primary endpoint was met with the 2-to-1 randomization, with improvement for mosun pola versus R-GemOx, with a 59% risk reduction in progression-free survival. And this was presented by my colleague Jason Weston at the ICML meeting last year. In exploratory analyses across all the major subgroups seen in this trial, mosun pola improved progression-free survival in all the clinically relevant subgroups, both in the relapsed and refractory patients, and as well as in second-line and third-line plus treated patients. When you look at adverse events, and this slide shows those at the left that were more frequent with mosunetuzumab and polatuzumab versus those that were more frequent with R-GemOx. As might expected, the R-chemotherapy regimen had more cytopenias and thrombocytopenia, neutropenia, and anemia. There was cytokine release syndrome, albeit in a relatively small number of patients, only 20% of patients seen in that group of patients, and the majority of those were grade 1-2 cytokine release syndrome. And that's shown in more detail here, with 21% of patients having grade 1 cytokine release syndrome in the Mosin-Pola arm, and only less than 1% had grade 3 CRS in this study. The next study that I'll turn your attention to is this combination. So another bispecific antibody, glofitamab and polatuzumab. This was part of a phase 1b/2 clinical trial that was recently published by Martin Hutchings in the Journal of Clinical Oncology. And that group is shown at the bottom of this slide. When you look at the results of this study, glofitamab and polatuzumab had quite a high overall response rate, occurring in close to 80% of patients, with 59.7% of those being patients who received a complete response. And this is quite a bit higher, about 20 percentage points higher than what was seen with glofitamab alone, in albeit a relatively similar patient population. And when you look at the progression-free survival shown in this study, the group that received glofitamab and polatuzumab had a 24-month event rate of 42% progression-free survival shown at that time point. And you can see in the curves to the right that those benefits curved fairly evenly across diffuse large B-cell subsets that were seen in this study, although the majority of the patients had either high-grade B-cell lymphoma or standard diffuse large B-cell lymphoma not otherwise specified. And the final study that I'll mention is the POLARGO study. So this was a phase 3 trial of Pola-R-GemOx versus R-GemOx. Yet another study that uses the R-GemOx comparator. And you can see in the overall survival curves and progression-free survival curves to the right that this achieved a median, with a median follow-up of 24 months, a benefit with a hazard ratio of 0.6 for the Pola-R-GemOx arm, for overall survival, and hazard ratio of 0.37 for progression-free survival, demonstrating a benefit for Pola-R-GemOx in this setting. And so with that, I'll close, and I think we'll go to our second opinion cases.
Great. Thank you.
Good evening, everyone. In our unique second opinion CME format, I meet with clinical investigators and ask them to come up with interesting and relevant cases and questions for the faculty to discuss. Tonight, we focus on novel agents in the management of non-Hodgkin lymphomas, and I met individually with Dr. Anne Lacasse and Dr. Gilles Sal. To begin, Dr. Lacasse presented a 79-year-old woman who initially noted a neck node, which led to the diagnosis of stage 4 non-germinal cell diffuse large B-cell lymphoma.
This is a woman I met fairly recently. This was her baseline PET, which was really quite impressive. Really, her entire liver was replaced by DLBCL, and she had multifocal other sites of disease, including in bone marrow and nodal sites. So she had stage 4 disease, IPI4. So she's someone I treated with polatuzumab plus R-CHP. She had 3 cycles of therapy and had a metabolic complete remission. She just finished her treatment. I'd love to know how the panel would approach a patient like this with diffuse large B-cell lymphoma, whether you would give any patient with an IPI of 2 or greater Pola-R-CHP based on the data from the Polarix study, where they, it was not powered to look at these subsets, or do you use cell of origin to determine who you would give? Are you using a gene expression profiling assay, or are there any other type of testing that you would use other than cell of origin, which we know, is not perfect? We've talked a lot about CNS prophylaxis. We're not typically doing it. Is that something that anybody on the panel would think about doing? We know that CNS relapse is a dreaded outcome in patients with diffuse large B-cell lymphoma. And how do you think about better identifying who's at risk? What about ctDNA in the CSF? Is that something that you think we should be starting to examine and use in routine clinical practice? And just thoughts on how that may play out over time.
Okay, so some discussion questions for our panel. So let's start with a newly diagnosed large cell patient. If you have somebody with a high IPI score 2 or higher, Chris, we'll start with you and we'll just go down the line. Does everybody in your practice get Pola-R-CHP, or are you using a cell of origin determination to make therapy selection?
Yeah, great question, Brad, and great question from Ann. I think the real challenge is that all the data that we have that are published from the randomized controlled trial are based on using a gene expression profile-based assay to be able to determine cell of origin for making those decisions. And we know from the Hans algorithm, while it's useful, that there's 20% misclassification of patients. And so I don't feel comfortable with 20% of my patients getting the wrong therapy based on the tests that we're using. And so IPI 2 or greater is really the criteria that I use and many in our practice use for making a decision about whether polatuzumab should be included in their regimen. As I showed in my slides, we're trying to use approaches with gene expression profiling, and we'll be testing that in a study for incorporating that into clinical practice. As of right now, there is no group that I know of that routinely uses gene expression profiling in clinical practice other than the group in British Columbia. And that group doesn't have Polar-R-CHP approved for general use in the population. And so that's part of why they're using that as an assay. And so the other thing to note is that when you look at that subgroup analysis, there are multiple other subgroups that also benefited. So other groups include patients with an IPI of 3 to 5 that had a greater benefit than similar to that cell of origin selection. And so if you had a GCB patient with an IPI of 3 to 5, I don't know how you should be making decisions based on IPI alone or based on cell of origin alone. And so IPI 2 or greater is really the criteria that I use in general.
Yeah. How about you, Sonny?
Yeah, I mean, I think Chris said it really well. And I'll just say that this has been a debate at almost every meeting, is like you debate with Pan-Pacific, ICML, R-CHOP versus Pola-R-CHP. And, the answer is, why do we think that cell of origin supersedes any other high-risk factor, on that forest plot? And so I think, I'll follow the label. The one thing that I will call out, though, is that, as we look at, I think this may evolve over time because, certainly the genetic classifications suggest that there are, very precise and specific subsets that derive the majority of the benefit from using a Pola-R-CHP approach. And so if somebody has C5 and that, it really makes you feel good. I think in Ann's case, the fact that it was non-GC cell of origin, that's also a good factor, that makes you lean toward it. I think if it had been a germinal center diffuse large B-cell lymphoma, this would be a little bit of a robust debate, but I would still use Pola-R-CHP if available. Sorry, I'm going to say one more thing.
Sure.
Sorry, which is this woman is 79.
Yeah.
And so I don't know, I actually, she asked the question about what you would use. And quite honestly, I think this is a really tricky age group that can fall apart very quickly. So we need some better specific tools for that.
Yeah. Matt, do you use any cell of origin determination to choose your first-line therapy?
I think when it's a non-GCB patient, it's a little bit more straightforward. I think and Dr. Flowers presented the dark zone signature patient population that you guys are studying with dose-adjusted EPOCH-R. We know that in the POLARIX trial, about 1 in 5 patients buried in the GCB portion were those dark zone patients. And I know it tracks a little bit along with the double hit population, but she didn't offer that. And I'm sure it's an 8 non-GCB, so we assume that it's a non-double hit or your classical MYC and BCL2 rearranged patients. Short of this, I think that the patient would have gotten, in Nebraska, would have gotten Pola-R-CHP or a clinical trial. I think there's a lot of really good clinical trials going on right now. I think the GCB question, if this had been GCB, we would have been prioritizing a clinical trial for this patient. We have, the wave line trials with zilovertamab kind of going through now, which are still asking the question in the control arm, what's the GCB, recapitulating the POLARIX data in that Pola-R-CHP population, but also trying to add things to it. I think we can all reflect upon the days of R-CHOP alone are probably numbered.
Mm-hmm.
So let's go to the CNS prophylaxis question, and we'll switch our order. Matt, I'll start with you. I believe this patient had a relatively high-risk CNS IPI score. I think I heard 4. Would you have offered CNS prophylaxis to Ann's patient?
Yeah, so I reflect on renal, adrenal. That's pretty much the organ in my case that I will kind of commit people to some sort of IT methotrexate, depending upon age, I have given IT methotrexate on the back end, or excuse me, high-dose methotrexate on the back end. Here, I'm usually very conscientious about what Dr. Smith said, which was the first cycle often tells you a lot about what's going to happen with the course of this patient. So if I'm going to do CNS prophylaxis, I usually start at cycle 2 and give them kind of an unadulterated cycle 1, understanding if they have no CNS symptoms, it's unlikely that they're going to come out in that first cycle if I haven't already thought about it as a concurrent diagnosis. And so then I often do a one and done approach where I'll do one intrathecal at cycle 2, and I'll give intrathecal methotrexate. If the cytology and flow is negative, then I basically say I'm done.
Sonny?
I would perseverate. What do I do? Do I do it? Do I not do it? But I think, quite honestly, we have, pretty good retrospective data that CNS prophylaxis, the way in which we have it today, does not really benefit the patient. And at 79 years old, I would not offer any CNS prophylaxis. There was actually a really great abstract on Friday at the rapid oral sessions here at ASCO, looking at applying both DLB class and LymphGen and UCSF in-house assay to patients with diffuse large B-cell lymphoma, and almost all of the secondary CNS lymphoma cases occurred in the C5 MCD group. So I think we'll learn more about this over time too.
Yeah, I thought that abstract was really interesting. Yeah. So if this patient had C5 MCD, are you going to give her? Are you going to give her prophylaxis?
Probably, I would perseverate even more, and then if she did well at the end, maybe I would. I honestly, at 79, I probably wouldn't.
No, I agree. I agree with you. This is a very, very challenging situation for a patient at 79. I think one of the things that's been a particular challenge in diffuse large B-cell lymphoma is if you look at kids with ALL, the reason why we give CNS prophylaxis to kids with ALL is that kids with ALL can be cured of their ALL and relapse in their CNS as an isolated CLS disease and die from CNS disease without having systemic disease. The majority of the time when patients with diffuse large B-cell lymphoma relapse in the CNS, they also have systemic relapse. And so I agree with you that, all the observational data that we have now for intrathecal methotrexate and for systemic high-dose methotrexate suggests that that's not reducing the risk of CNS relapse. And so if I were going to give it, I would do something else, and that's what I do sometimes for these patients. I don't know if that helps the patient. It helps me sleep at night better that I'm giving intrathecal methotrexate and ARAC or something else like that to hopefully prophylax. But for somebody 79, I worry a lot that you might be causing more harm than good.
Sonny, do you see a role for these molecular techniques or ctDNA techniques in the CSF as being a better tool to identify high risk?
Yeah, I do think that ctDNA in the CSF is going to be very useful as we go forward. But I also agree with Matt that I would not do it with the first cycle. I think that often I will wait on the LP until the second cycle, especially if the PET scan's negative and, if you're concerned to see
no symptoms.
Yeah, no symptoms and, negative imaging.
Yeah. Okay, let's move on. So let's go to our second case from Gilles.
Antibody-drug conjugates, particularly polatuzumab vedotin and loncastuximab tesirine, or LONCA-T, have yielded interesting trial results in a variety of settings in non-Hodgkin lymphoma, and Dr. Sal was curious about the faculty's perspective on combination regimens.
In the recent 12 months, we have seen phenomenal results regarding the combination with antibody-drug conjugate and bispecific antibodies. This was in the first-line setting with a combination of polatuzumab and glofitamab in older patients. And we have seen also the loncastuximab glofitamab early result. What are your thoughts about this result? Do you think this will move forward? Can we bring that even to the front line of patient before chemo or instead of chemo? How do you foresee the future of these combinations? The field is moving extremely fast, and there is something probably biologically interesting in this combination of cytotoxic agents that penetrate directly into the tumor cells and the efficacy of bispecific, which may be enhanced as compared to a combination with chemo. So I think we should really think whether this combination can be used not only in non-chemo eligible patients, but also as before chemo.
Okay, what are your thoughts on recent data combining antibody-drug conjugates and bispecific antibodies in DLBCL? How enthusiastic are you about the potential use of frontline rituximab, polatuzumab vedotin, glofitamab, the so-called R-Pola-Glo regimen for unfit older patients? Would you use this regimen today for any of your patients? I'll start with Matt on that one.
I'm actually excited in the field of where we've come. I mean, this population that we're finally studying was often left behind in clinical trials, right? That you saw in the POLARIX trial over, they capped it at 80, probably just to make it a little bit easier to carve out that population. But it did leave 20% of our patients behind when we say that they're getting a mini CHOP type approach. And now we're seeing, data that looks very impressive with I call RPG or rituximab pola glofit. We've actually seen multiple trials of either doublets or even singlets now coming in. I think really the true challenge is going to be discerning what is the control that's appropriate for a randomized trial, and then whether or not it's ethical to not allow crossover in those trials, understanding that the FDA hasn't been too keen on crossover, and what's going to be the endpoint. I think a lot of us really want an overall survival primary endpoint in frontline large B-cell lymphoma. And we've now got multiple studies, which are PFS is positive, but OS is not, showing that we've gotten a lot better in second line and beyond with bispecifics and CAR T-cell. But is this the population where we can actually go after OS as a primary endpoint? And if we do that, you are going to probably get 50% of the patients getting R-mini CHOP and the other half not getting or getting the experimental arm, and limited control over what they get second line. So I'm actually phrasing more questions than answering your question. But I'm really excited that we're actually studying this population now and allowing them to get into prospective clinical trials.
Sony, I know you've put a lot of thought into this older DLBCL population. So where do you think the field is headed there?
Yeah, I think that our mini CHOP is a really terrible standard that needs to be beaten up and thrown away. So I think we're getting closer to getting a chemo-free or a chemo-light regimen. And I think it's really important to study this carefully because, we also know that chemo-free is not always toxicity-free. But that being said, I think the initial data that we saw at ASH last year with R-Pola-Glo is very encouraging, that it's safe, it's feasible, and there's very, really exciting efficacy that we're seeing. So I'm not using this regimen today. I think it needs to be studied, and hopefully, we can move the field forward. The one thing I'll just say about the overall survival benefit in older patients is that it's confounded both by second-line treatment, which is getting better and better, including CAR T, and that there are competing risks for death as people get older. So.
Yeah, but do you not think that our mini CHOP will be the thing that it has to beat up?
Yes.
Right.
It has to go away.
So it's going to be the R-GemOx. It was chlorambucil obinutuzumab, and CLL got beat up, and then R-GemOx is now getting beat up in relapsed refractory large cell, and the next candidate to get beat up is our mini CHOP.
There you go.
Okay,
I agree.
I like it.
I agree.
So let's talk about these newer options in relapse large cell, Chris. So we have now NCCN guideline inclusion of POLA in combination with Mosun, POLA in combination with Glofit, POLA in combination with our GemOx. So 3 new options, relatively new options that include POLA and different combinations, 2 with bispecifics, ones with our GemOx. Are you using these regimens in your relapse patients, and how do you choose a regimen for a patient?
Yeah, so these are all regimens that we are using in various combinations for our patients. Commonly, we're thinking about these as bridging regimens to get to CAR T, also using them in patients who have had relapse after CAR T. And so I think The real challenge there, though, is that we don't really have good biomarkers to help us to understand which of the regimens are the best regimens to use in particular situations. And I think that's the place where we really need to go to be able to better understand when bispecific antibodies may be most useful. At this meeting, one of our fellows, Andrew Harkins, who will join us on faculty, presented data from a biomarker that Michael Green from our group developed, a lymphomap biomarker that is a gene expression profiling-based assay that was first tested in CAR-T in the ZUMA-7 study that showed that patients that have a T-exhausted phenotype by their gene expression profile in their microenvironment do not have a benefit for CAR-T over autologous stem cell transplantation. And I think those kinds of approaches need to be tested in these settings to know when and where bispecific antibodies may be of value.
Matt, let's talk about Lonca for a minute. So Lonca has now been tested in combination with glofitamab in relapsed diffuse large B-cell lymphoma. What kind of potential do you see in this regimen?
I think arguably it's one of the hottest trials that is still open and you can put patients on. And I'll show a little bit of the data later in my presentation. I think it is one of those that when you see the data, it's hard to keep this from your patients if you don't have access to the clinical trial. And that's been a kind of a conundrum on how, if you so choose and go through the risk-benefit discussion with the patient. And practically, I don't have a lot for these patients after they relapse post-CAR T-cell. And I don't, if they're really early relapses, then I'm really concerned that a CD3, CD20 bispecific isn't going to be enough. It's just, can I get access in a sequential fashion of giving the Glofit first and then adding the Lonca a little bit later? And I think that's not the way the clinical trial is doing it, but, both drugs are approved and, I would and have tried to use this regimen already.
Great. Okay, I'm going to take us forward. Let's move on to Module 2. Dr. Smith will talk about clinical utility of CD19-directed monoclonal antibodies in the treatment of diffuse large B-cell lymphoma and follicular lymphoma.
Okay, great. So, all right, just as Brad said, I'm going to talk about CD19-directed monoclonal antibodies, and a couple of points. I'm going to talk about mature data from the phase 2 L-MIND data and relapsed refractory DLBCL, and then hot off the press, phase 3 frontMIND data that was presented on Saturday. And then I'm going to switch to follicular lymphoma and talk about the phase 3 InMIND trial that had, some really great data presented at ASH 2025, and then end with some toxicity discussion. So everybody here knows that CD19 is a really important target. It's a pan B-cell antigen that actually has broader expression than even CD20. But unfortunately, when we tried to replicate rituximab, it turns out that naked antibodies have zero efficacy in this disease. Luckily, we did not abandon CD19, and as you can see in the two cartoons to the top right, we know that CD19 is actually part of a signaling complex that has both B-cell receptor dependent and independent pathways, and that also it internalizes within a lysosome. So it gives us lots of opportunities to take advantage of this protein, and you can see some of the ways that that's been done, in the boxes on the bottom. So what is tafasitamab? This is an enhanced monoclonal antibody against CD19. It has an engineered FC region that increases affinity to immune effector cells, and then when given with lenalidomide, which expands the effector cell pool and activation, there is some really great synergy. So L-MIND was a phase 2 trial that looked at tafasitamab plus lenalidomide in relapsed refractory diffuse large B-cell lymphoma, and we now have 5-year data that was presented not too long ago and published in full form. And just a couple of things to point out. One is that the median age was 72 on this study. And in fact, more than half the patients were over the age of 70. So I think that's really important when we're considering different treatments for our patients. The other piece is that this included both patients who had refractory as well as relapsed disease. So, and also that there was an analysis by line of therapy. So what the 5-year data shows, and I'm sorry that the boxes are a little bit out of order, but maybe look at the PFS curves and the overall survival curves. And what they show is that if patients received Tafa-Len in the second line setting, they had superior PFS and overall survival compared to patients in the third line or the overall population. And then after that, now look at the duration of response and the duration of CR. And what that shows is that regardless of the line of therapy, if there's a response and if there's a CR, then the line of therapy was less relevant. And I think this is kind of important, as we try to build upon it. So a lot of people have asked, does this translate to the real world? And the data on the left is not meant for you to read, but just to illustrate that there's a number of different investigations looking at real world data in very large data sets. And then I put a representative figure on the right that looks at a very large database in Europe from the Spanish group. And it shows, particularly if you look at the curve at the bottom left, that those patients who had a CR or a PR to tafasitamab and lenalidomide did really well. And, one other piece I'll just put in there is that this is a fixed duration regimen of only 12 cycles. So I think that's also very important. So what happened at ASCO this year? We had the results of the Frontline trial, which is a randomized phase 3, multi-center international placebo-controlled double-blind randomized trial. And there's about 450 patients on each arm. The couple of things to point out about the Frontline trial is that this was actually a really high-risk group of patients. So we talked about the Polarix trial, which was IPI 2 to 5. This is IPI 3 to 5, okay? So you might say, what difference does another IPI score mean? I actually think it means quite a bit. Primary endpoint was progression-free survival. And if you dig into the demographics and baseline features, 80% of the patients had an elevated LDH. 30% of patients had a poor performance status. And then when you look at that IPI, about 40% of patients, 40 to 45% of patients had a high risk IPI of 4 to 5. This is a really sick population. So we saw the primary endpoint presented, and this shows that there is a 25% reduction in the risk of progression or death with a 2-year PFS difference of 71.1% for the investigational arm versus 62.9% with R-CHOP. And I was noting that in the Polarix trial, that was 70% for R-CHOP. And so this might be, maybe because it's a higher risk population, that's what we're seeing. So the delta there is 8.2%. And at 3 years, there's a persistent delta of 6.6%. In terms of event-free survival, you can see right here that the 2-year and the 3-year EFS, hold strong, 65% versus 56% in favor of the tafa-len arm. And there's a really nice flattening of the curves. And then, of course, overall survival, which is really hard to show a difference. I don't know. There may be a trend here. This certainly numerically 84%, 84.1% versus 80.5%. But certainly we'll have to see how this pans out with longer follow-up and knowing that our salvage approaches are improving all the time. And then here is the hazard ratio for centrally confirmed lymphoma subtypes. And the difference here is even greater. So they found out that they had about 14% of patients in the initial population that actually did not have the lymphoma they were trying to look at, which is diffuse large B-cell lymphoma. And so if you look at the patients who truly had DLBCL, this is the delta, and it's, nice to see. They did also look at the cell of origin types, and you can see the difference here. And the important part is on the forest plot, which is that cell of origin did not make a difference in terms of efficacy. And neither did some of the high-grade B-cell lymphomas, even though it was a smaller number of patients, compared to DLBCL and OS. The overall response rate and the CR rates are shown here. These are high on both arms, but the PET negative CR rate and the PR rate was numerically higher in the tafa-len R-CHOP arm. So I'll switch to follicular lymphoma and just remind everybody that, in the second line and beyond, lenalidomide and rituximab is an effective regimen and backbone that we use all the time. I mean, R squared, has been around. And a lot of the reason is because of the AUGMENT trial on the left side that shows that there is improved progression-free survival and overall survival for rituximab-sensitive disease. We also know that PFS and OS decrease by line of treatment. So what did we hear at ASH last year? We saw the results of the InMind trial. This was a phase 3, double-blind, placebo-controlled, international, multi-center randomized trial of tafa-len with rituximab. So it's tafa R squared, I guess that's another way to say it, against placebo/R squared. And they looked at POD24, they looked at refractoriness and the number of prior lines of therapy. And then the primary endpoint here was progression-free survival. So, what was notable in this particular study is that the median age, first of all, was 64. But again, there's a significant, portion of patients, 20% in this one, roughly, that are over the age of 75. And then the other part, which I originally, when I heard this presented, they didn't say that you needed symptoms to start. So in other words, patients did not have to have GELF criteria. However, when you then go back and look at the patients who were enrolled, 80% of them actually met an indication for therapy. And so I think this is a very appropriate population, for us to think about. A third of patients had early progression of disease, and then about 50% or 54% had relapsed disease, and 41% had refractory disease. Again, remembering that those patients were not included in the Augment trial, which was specifically for relapse disease. And so kind of in the very bottom line of this table, refractory to prior anti-CD20 therapy is about 43% in the TAFA R-squared arm and 41.8% in the placebo. So overall, 20% of patients were over the age of 75, 80% met GELF criteria, a third had early progression, and 42% were refractory. So with that, these are the curves that were generated. And you can see, it's, a significant improvement over R-squared with a median progression-free survival of 22.4 months versus 13.9 months and an impressive hazard ratio of 0.43 and a p-value that is significant. They also looked at some of the pre-specified groups. And what you can see here is that this the TAFA R-squared is active, independent, or regardless of the POD24 status, refractory to prior anti-CD20 status, and even the number of prior lines, 1 or 2 or greater. So what we saw more recently were some additional sub-analyses. So here is the progression-free survival by POD24 status. And what you can see in the green lines, which is just R-squared, is that there is a difference. So if you look at the top two curves, the green line drops if there's POD24. And although the blue line drops a little bit, it's more similar to the without having POD24. And the same thing can be said for the bottom two curves, which looks at refractory status to anti-CD20. The other sub-analysis they did was to look at progression-free survival by line of therapy. So, this is really important to us in clinic, right? Somebody with follicular lymphoma has a recurrence. Are we going to use R-squared? Are we going to use something else? Second line, third line? We have no data on sequencing today. But I think what, this type of data speaks to is that using this in the second line setting, is really, really robust. There's also activity in the third line setting, which I don't think was present when we saw the initial analysis, but we're seeing this now with the longer term follow-up. If we look at the patients who were enrolled on this study, median age is 64. We have a high risk FLIPI in 50% of patients, and we have high tumor burden as per GELF, as we already talked about. Here are the results with the PET-CR and the overall response rate. And what this shows is that, the complete metabolic remission and the overall response rate were higher for those patients who had the additional tafasitamab. And the PET-CR rate, you can look at the bottom on the left, shows that it's 49.4% versus 39.8% with an odds ratio of 1.5. So what about toxicity? Is there anything special we need to know about tafasitamab and lenalidomide when given together? So this right here is from the Frontline trial. So this is from the Tafa-Len plus R-CHOP versus R-CHOP study. And there are some increased adverse events in those patients who get the additional antibody, which are cytopenias, and perhaps a slight increase in febrile neutropenia. I would say that, I was at a quality symposium and they said we should never say that these are acceptable toxicities, but they are manageable toxicities. So I'll just put that out there. Nothing that we did not expect occurred here. When we look at the follicular lymphoma data set, these are the treatment emergent adverse events that occur in more than 15%. And, overall, there is no new safety signal here that we did not already know. perhaps, one of the things that we always worry about when we have lenalidomide in any combination is rash. That was not increased in this particular, adverse event, evaluation. And cytopenias were similar, just a little bit increased with neutropenia and febrile neutropenia. So when it comes to dose modifications, both the tafasitamab and placebo dose interruptions due to treatment emergent AEs were actually similar between both arms. Dose delay or interruption occurred in 74% versus 70%. And in terms of people who stopped treatment, it was roughly around 7 to 11% and no significant difference. Lenalidomide is sometimes a tough drug, but again, the discontinuations were similar between the two arms and the dose reductions were the same between the two arms. So I think that's it.
Okay. Thank you, Sony. Let's go ahead and play the next case.
The combination of tafasitamab, lenalidomide, and rituximab, TAFA-R squared, is an important treatment option in recurrent follicular lymphoma, and Dr. Lacasse provided her take for your input on how this fits into the treatment algorithm in the age of bispecific antibodies and CAR T-cell therapy.
The tafasitamab, lenalidomide, rituximab data was impressive in terms of its tolerability. We have a lot of patients who have hypogammaglobulinemia, even from their frontline therapy, or patients who have difficulty with recurrent infections. Tafasitamab is a very well tolerated drug in general. And, I think that a patient who maybe was more frail and you were worried about CRS, I think could be given very well in the community with good safety profile. So I think that it is an appealing combination with regard to tolerability in particular. And I think the efficacy data looks quite good. So I think it is a good option. I have a question for the panel. There was a little bit of data in the TAFA-R squared study looking at risk of transformation. And there were no cases of transformation on the TAFA-R squared arm compared to, a small but significant number on the lenalidomide plus rituximab arm, which has, I think, generated some discussion about using a CD19-directed therapy and trying to eradicate potentially, a precursor cell that may give rise to transformed disease. And I think with follicular lymphoma, what we worry about the most is transformation and being able to effectively manage those patients. So I would love to hear the panel's thoughts on, do you think that was a real finding? Does that make you think about using tafasitamab more readily when you compare it with a bispecific antibody?
Okay, let's do some discussion questions. Let's start with TAFA-R squared for relapsed refractory follicular. Life got a lot more complicated, this past year with EPCO R squared data becoming available. So how do you choose between EPCO R squared and TAFA R squared when you have a relapsed follicular lymphoma patient before you? I'm going to start with Matt.
I'm going to have this discussion tomorrow, actually, I think. So, I really like Ann's point about 0 transformations in the TAFA-R squared. There were 9 transformations in the R squared arm. So I think that's mathematically, that with the number of patients, that's I think a meaningful difference to me. When I think about the logistics of, both regimens, I think they're fairly the same, kind of button chair time, if you will, and travel time. That's a lot of visits for both EPCO and TAFA in combination to the lenalidomide. At least in TAFA-R squared, I think the lenalidomide is the driver of the toxicity, not the tafasitamab. I think in EPCO-R squared, it's equally shared with EPCO and lenalidomide probably driving both. I think one of the things we have to be conscientious about whenever we're giving lenalidomide is, the dose matters. There's a right dose of lenalidomide for everybody. It just might not be 25 milligrams if you're talking about frontMIND, and it might not be 20 milligrams if you're talking about your R squared backbones here. So I always educate around, look at the creatinine clearance. If they're always hovering around 60 per meters mils per minute, then I'm actually dose reducing them, because I haven't seen a patient who gets lenalidomide and goes, that makes me drink more and I have more energy and I have less diarrhea. if anything, they take their lenalidomide and their GFR is going to actually go down because of the medicine rather than go up. And so I will actually hedge and start at 10, just based upon the creatinine clearance of 30 to 60 from that standpoint. I also think about sequencing, because if there's one thing, I can give TAFA R squared, and then if they progress after that, I still have EPCO at my disposal as a single agent that works very, very well. Understanding that there wasn't a ton of patients in the EPCO follicular lymphoma experience that had prior actually R squared in general. I can't do the inverse, right? I'm not going to give EPCO R squared and then go back and give tafasitamab monotherapy, or maybe if they got a long enough duration away, then I would consider TAFA R squared if they had all sorts of EPCO or EPCO infection issues. So a lot to unpack in this, but I think, again, R squared is probably done for a lot of people in follicular lymphoma. And the ironic thing is we're still giving it in now in the frontline randomized trials post publication of both TAFA R squared and EPCO R squared.
So, Chris, do you ever see yourself just giving R squared in relapsed disease, or is it always going to be a 3-drug regimen now?
Well, I think one of the challenges that we've faced with 3-drug regimens in follicular lymphoma, in mantle cell lymphoma, in CLL, maybe also in myeloma, is that oftentimes when you're looking at a 3-drug regimen, we don't have good data to show whether giving that combination as a 3-drug regimen or giving one of those as a singlet later on may give similar benefits in terms of PFS too. I think that's a little bit different for tafasitamab R squared for reasons that Matt elucidated, and to the point that Sony made at the very beginning about the mechanism of action. We would not give tafasitamab by itself after giving R squared. And so either you're going to give it in combination with R squared or you're not going to give it at all. From the data that you showed at the end, Sony, the additive toxicity of tafasitamab is relatively limited. And so I think, that's providing benefits to patients in terms of PFS with limited additional toxicity. What we don't know about epcoritamab R squared is whether giving that combination is providing benefits over giving R squared followed by epcoritamab. But I think there will be selected situations where patients we'll still get R squared as a combination. I think the things that we will need are biomarkers, and one of those is CD19. I think in a patient where there is no CD19 expression, I don't think there's a rationale for giving that combination.
Sony, if you have a patient who's had prior CD19 exposure and you're thinking about another CD19-directed therapy, are you biopsying every chance you get, half the time, none of the time? What's your approach?
I think my practice is really driven by getting a biopsy prior to starting any new regimen. So I end up getting that information, although it's not specifically, to see what's there, but that's part of it. I actually have a 91-year-old right now who lost CD20 in the relapsed refractory setting, and CD19 is preserved, and it really, helped. Like that was really fantastic to know that. So, yeah.
Yeah, I think we're going to see a renaissance of biopsies, actually. I think that's one of the things that's really going to be nice here is, really confirming the diagnosis and you having a strategic approach based upon what you've done before may change, and then what you wait to relapse may reemerge. So therapies that you wouldn't have done first, you may do the next time.
Let's go to our next case.
Tafasitamab also has significant clinical activity in diffuse large B-cell lymphoma, and at this point in the ASCO meeting, the data from the Front-MIND trial, an upfront treatment of DLBCL, which was previewed briefly earlier this year in a press release, will now have been presented. Dr. Kahl is interested in your perspectives on the reported outcomes.
Front-MIND study is a study that builds on the efficacy of the combination of lenalidomide and tafasitamab, and it's for newly diagnosed patients with diffuse large B-cell lymphoma. The control arm is 6 cycles of R-CHOP, and the experimental arm is a combination of R-CHOP plus lenalidomide plus tafasitamab. Tafasitamab is used as a quite intensive scheme, which is weekly infusion during the 6 cycles of R-CHOP, so frequent administration of the drug. There is a significant benefit in terms of PFS. And what do you think is the way some patient may eventually be candidate for this particular regimen. The question is, are we getting progress in patients with GCB DLBCL? And one of the next questions of the frontline trial is whether the benefit that we observed is really significant for this patient with GCB subtype DLBCL.
Okay, there's a lot to think through here. It almost hurts my brain. So, you have seen the frontline data, had 2 whole days to digest it now. How are you putting this frontline data in context? Is there a patient that you can envision giving this Tafa-Len-R-CHOP regimen to in 2026? Chris, I'll start with you.
Yeah, maybe a couple of general comments about the study first, and Sonny touched on some of these. Well, Matt Maurer and I had input on the eligibility criteria for this study, and some of the things that were unique is this really was selected to be a population of patients that were at very high risk. First was the IPI 3 to 5 selection, but these were all patients who had a diagnosis to treatment interval of less than 28 days. As a component of that. And we know from historical data, both from Mayo and Iowa, and from the French group that Gilles was part of, that those patients who have a diagnosis to treatment interval that is longer tend to have more favorable outcomes. And it's really those patients less than 28 days that have the worst outcomes. That's not to say that if you have a patient that's 29 days out for their diagnosis that you should not use this regimen, but just to know that this is a very unfavorable population, and that's probably why the R-CHOP outcomes were not as favorable. I'd like to see more follow-up on this study overall. And then secondly, is the toxicity associated with this regimen. You have to give the combination of tafasitamab and lenalidomide together as part of this, so you can't give the tafasitamab independently. And there was more cytopenia and more infection associated with that. And this was a regimen that is a little bit more difficult to give than just standard R-CHOP. And so I think you'll need to identify robust patients who can tolerate a regimen like this to be able to move forward, who fall into those higher risk categories. Maybe the last point that I'll make is this whole notion of GCB and ABC is about to get way, way, way more complicated than it is now. There's a paper that's already out there from Lou Stout's group that came out in Cancer Cell just a few weeks ago that used a single cell sequencing approach and essentially shows that if you use either a bulk or pseudo-bulk approach and identify patients who have either ABC or GCB subtype and then look by single cell, there are patients who have ABC subtype who have single cells of malignant B cells that are GCB subtype. And so I think the regimens that we use need to be addressed in a more complicated way. We also have unpublished data that show the exact same thing. And so I think there's much more to be learned about the biology coming forward.
Sonny, do you see yourself using Tafa-Len-R-CHOP in the near future?
Yeah, so I wanted to just address 2 things that you said. So one, the messiness of the cell of origin that you just alluded to, I think that's really important. And the fact that 20% are misclassified is important to remember. But that being said, given the discussion we had about the Polarix data, if I have a high risk, diffuse large B-cell lymphoma, patient, and this is approved, I would consider. But then that brings me to the second point, which you talked about with the toxicity. There's also a time toxicity associated with this regimen in that the tafasitamab is given weekly for all 6 cycles. And that's not always a possibility for a lot of my patients.
Matt.
Yeah, I think there were some unanswered questions from the front line. I think Chris answered it. In the first line, we knew we had to give lenalidomide, right? From that, 66 patients that were randomized, that the lenalidomide was definitely adding some contribution margin here. I really want to understand from the trial what was the len dose intensity throughout. That was something that wasn't presented in the abstract. It was more focused on the CHOP portion of it rather than the lenalidomide. And then when you looked at the toxicity tornado, you saw neutropenia there, but in that entire population, everybody was getting a CBC again and again and again. So they had more opportunities to actually have adverse events comparatively to POLARIX, where you were giving it and then forgetting, and then 3 weeks later, and the only time you had an opportunity for an adverse event is if you actually had a for-cause reason to go in. It wasn't protocol specified. So I think that there are some of those unanswered questions. And then, 18 doses of tafasitamab versus could you have just gotten away with 6 doses of tafasitamab and made it a much effortless. I think Lori did a nice job at her presentation of saying effortful, but make it more effortless, here to help drive the field forward. But certainly the driver of the toxicity, was the len plus the CHOP. It wasn't the tafasitamab from my perspective. I think if I'm going to use it outside of a clinical trial, it's going to be in a GCB patient with a high IPI.
Gotcha. Any concern about the CD19 exposure and burning bridges for second line or third line CAR T? Sony?
Yeah, I mean, that's the big unknown. But I think the main piece here is that we have some data in the relapsed refractory setting. It's very small that CAR T is feasible post-TAFA exposure. It's very small data sets, but, it is a concern. But I also, if you come to, highlights of the year tomorrow for ASCO, I have a slide showing that only 5% of eligible patients in the United States actually get CAR T. So,
only 5.
Only 5.
Wow.
Yep. So, it may not be as big of a question for outside of the CAR T centers.
We have questions from the audience. Here's a question I think I just asked. Is Frontline ready for prime time? It sounds like everybody is saying, need to see more, having a hard time figuring who you would give it to, maybe a high IPI GCB. Is that what I just heard?
Non-double hit. And sometimes, to Chris's point about time from diagnosis to treatment, sometimes it's also about where you got your first cycle.
Yep.
Right? If you got in the ICU versus the hospital versus the outpatient, in 28 days versus beyond 28 days, sometimes I think that those drive a lot of the endpoints too.
Yeah. But these would also need to be fit patients and patients that are willing to come back weekly, as Sonny pointed out.
Yeah, it's now it's a 7-drug regimen. It's a lot. Yeah. Okay. So we're going to move on. Going to advance. How is it tolerated compared to our CHOP? I think we just covered that. How does the tolerability compare to Pola-R-CHP? Any thoughts? Sony, you looked at this data pretty closely.
Yeah, I mean, I think that there's more cytopenias. Again, they're not 100% comparable populations, but I think there is definitely more cytopenias and more visits with the tafasitamab, lenalidomide, R-CHOP. What we did see, though, is that in these high-risk patients, that there is an improved PFS. So I think this is a discussion. But just from the tolerability perspective, I think the Tafa-Len probably has more toxicity.
My understanding, and you guys can correct me if I'm wrong, but there's a lot of countries where R-CHP Pola was never approved or is not approved.
Correct.
So I'm thinking this frontline regimen will have a bigger impact maybe outside the U.S. where R-CHP Pola is not available. Agree, disagree?
Yeah, as I've had discussions with colleagues not from the U.S., a lot of it is surprising to me around the access to lenalidomide, where it's actually easier to get lenalidomide than in their clinics than it is in mine, and it's actually less expensive from that standpoint. So I think geographically, you're right.
Okay. So we're going to move on to Module 3, optimal use of CD19-directed antibody-drug conjugates for relapsed refractory diffuse large B-cell lymphoma and follicular lymphoma from Dr. Lunning.
All right. So if somebody gets the topic of of no data at ASCO, it's going to be me. And I'll play that for my NSYNC song here, because we're going to talk about 5 different characters with the utilization of Lonca-T-Dex. And I call it Lonca-T-Dex for a reason, right? Because it's Lonca-Suximab Tesirine. But dexamethasone was really, I think, what unlocked the therapy, bringing it to more people with more willingness to give it, because I think it did risk mitigate the toxicity that we were concerned about, namely the peripheral edema, pleural effusions, and pericardial effusions. So we're going to walk through here to the LOTUS-1, the LOTUS-2, the LOTUS-5. And then, as I alluded to, the what would be arguably the best-looking NSYNC member, but also the best-looking clinical trial right now is LOTUS-7, which is your Glofit Lonca. And then what I call the LOTUS-U. So for those of you who know the U, if you do this, I'm talking about the University of Miami, where really a lot of the Lonca-Suximab IIT with regards to follicular lymphoma was generated. So I think we can reflect upon that we have done a great job through getting the right clinical trials, so the right patients, and actually getting active drugs to market. And this is just kind of reflecting almost over a decade now of progress. I can reflect back to my fellowship when we were still discussing, ofatumumab versus rituximab in second-line large cell lymphoma with a platinum-based therapy and trying to improve upon high-dose therapy and autologous stem cell rescue. Right. This is all since then from that standpoint. And so, like I said, I'm going to focus just on Lonca-Suximab Tesirine or Lonca-T-Dex. And so Brad and I were reflecting upon a past meeting along the shores of what would be the Hudson River, and looking out and discussing Lonca-Suximab Tesirine, and which was not the name at the time, but the phase 1 trial. And how do we figure out to find a drug that we know has activity, but find the right dose and the right schedule? And I don't think there will ever be a trial like this again, where you have more patients in the phase 1 trial than you do in the phase 2 trial, right? And so this is just really a testament to trial design and pushing the pause button, saying, we know we've got an active drug here, but we really, really need to dial it in, not only on dose, but on schedule. And you can see here kind of what was taken out, and you can see that 150 micrograms per kilo went forward, and then 150 with dose reductions after 2 doses to 75 milligrams actually was the dose that went forward. But you can see here in indolent lymphomas, there was activity. You can see in diffuse large B-cell lymphoma, as a regimen or as a single drug, there was activity. All right. So once the dose and the schedule was sorted out, the phase 2, really we got to know this drug better, and we got to know this drug better in the setting of utilizing dexamethasone, so 4 milligrams BID the day before, the day of, and the day after. And that led in this relapsed refractory large B-cell lymphoma population to an overall response rate of 50%, with half of the patients achieving a CR. You can see here with those patients that in the whole treatment population, the median number of therapy was 3, but you could see those patients who got a CR, it could be 8. And those patients who had a CR and were event-free for 2 years got to that almost that full dosing of 13 cycles. And so I really keep this in mind, but I really think that this is an internist drug. You actually have to do a physical exam in order to figure this out, because if you're not feeling the pretibial region and you're feeling that kind of trace edema, that is absolutely the time to start spironolactone in this patient population, right? And that can totally take them back, and as well as focusing on what their weight is for the day. This is truly a finesse drug that you typically will see the responses with after 2 cycles, and I actually do response evaluations after 2 cycles, because if I'm not seeing improvement, I'm already thinking about what I'm going to do next, especially if I'm using this as a single agent. Because you can see here by PFS and OS, if you can generate a CR, those CRs can be durable. while it's only in a quarter of the patients, typically this is third-line large cell lymphoma, right? You were talking about, if you reflect upon, some of the data that was generated respective to Zuma-1, you're talking about median overall survivals of 6 months, and you're really talking about the opportunity to get a CR about less than 10%, and about 25 or 27% in that literature was obtaining any response. And so I think here, if you have patients that are getting into a CR, then trying to get more doses in this patient, but being very conscientious of the adverse event profile. So what was the adverse event profiles that I really pick up on? This increased GGT was something that was found early on in the phase 1 trial that really did come in to the phase 2 or LOTUS-2 trial. But I would ask all of you, if you ordered a GGT, when would you get that result? You would probably get that result the day after you gave the loncastuximab dex or the lonca-T dex. So what do I do in practice? Typically, I'm following the LFTs, which I can get back sometimes in my clinic in 30 minutes and sometimes in 3 hours. But if it's at 3 hours, hopefully there's enough time that I'm waiting for those LFTs and for our blood system to get back online because the subway system seems to break all the time. Nevertheless, this is certainly a regimen as you get into the relapse refractory setting that I do pair with long-acting growth factor to try to, what was the word you said, Sony? To manage the neutrophil or the neutropenia to try to subvert febrile neutropenia. And I've not seen that as a reason to hold back on tafasitamab or to hold back on lonca-T dex. The peripheral edema, I think we're doing much better as we educate on this drug, really leaning into the dexamethasone as well as the spironolactone early utilization. All right. So moving on to the third trial. So this is LOTUS-5. When you're really starting to get this drug humming, you then start to add with it. And so what's the easiest thing to bring to the table? Well, let's just sprinkle a little bit of vitamin R to lonca-T dex here. But let's go ahead and try and do a randomized trial and once again beat up on our GemOx. And so there was a safety run-in in the LOTUS-5 trial where they just paired Lonca plus R. And you can see here, small 20 patients. The overall response rate was 80% with a CR rate of 50%, remembering almost a doubling. But what should be known, the difference between the LOTUS-2 and the LOTUS-5 trials, the LOTUS-2 trial had a lot of refractory large B-cell lymphoma. LOTUS-5 had many more relapsed large B-cell lymphoma, so relapsed from their prior line, so arguably a little bit more sensitive patient population. Nevertheless, you're seeing some patients with responses that continue to be ongoing, and there was really no safety signals that made you go, whoa, we shouldn't be partnering lonca-T dex with rituximab. And oh, by the way, this trial was done during the COVID pandemic. All right. So as I talked about, this is the Justin Timberlake of the NSYNC trials. And so everybody, if you haven't been following the relapse refractory landscape, I would say that this is the hottest trial out there, arguably, in this space. And so this is pairing, you get obinutuzumab, followed on day 2 by Lonca, and then day 8 you lean into Glofit at 2.5, followed at day 15 with Glofit 10 milligrams, and then you hop into a combo data where you're giving Lonca plus Glofit, and then a little bit of Glofit chaser, cycles 9 through 12. So not only is it a fixed duration strategy, but it's really, I think, pairing these two drugs quite well. When I first saw this data, I didn't quite believe it. I think it's up to around 21 patients now, but you're seeing here with both overall response rates and CR rates, and this is a little bit older data that are approaching the 90% rate. You have very good 6 and 12-month PFS. I think really the tail of the tape is truly going to be whether or not there is real durability here, and can you start to use this in the post-CAR T-cell patient population. So I'm really, really excited to see longer follow-up. Unfortunately, you saw no LOTUS-7 at EHA, and I don't think, at least when I last did the abstract check, you're not going to see it at EHA. So no ASCO, no EHA for LOTUS-7, so maybe we'll just wait for the next winter event. You can see here just the CRs and where those CRs are getting. So you're getting patients who are actually getting into CR, and those CRs are durable. off of treatment. You can see here these are in studies in days. They would wish it was weeks or months. So early sledding still for LOTUS-7, but I really think that this is a very interesting combination. What about the toxicities? So yes, CRS is seen. This is glofitamab, but again, I think we're getting better at managing grade 1 CRS and really preventing it from getting to grade 2 through utilization of earlier pill in the pocket, dexamethasone, and keeping these patients at home rather than in our treatment centers in the middle of the night. And last, I'll call it LOTUS-U. And so you have to reflect upon where we were at in the phase 1 to actually see this signal. And so there were 14 patients in the phase 1. And you can see here there was pretty impressive response rate at 80%, with 65% of the patients achieving a CR. And so utilizing this data, Dr. Alaruccio and colleagues paired Lonca plus rituximab in the relapsed refractory follicular lymphoma landscape. You can see here the strategy of induction, maintenance, and then maintenance 2 based upon kind of their interval response. Here's the breakout of the patients, 39 at the time of this report, but you can see here this was I would argue, a reasonably treated frontline and then getting into their second line of therapy where the vast majority of the patients were getting treated. Again, recapitulating the phase 1 data with from a doing better actually, with 77% getting a CR and almost 100% getting an overall response or a response. I have gotten the opportunity, even though it's a class 2B in follicular lymphoma in the NCCN guidelines, I have used this in my N of 1 patient, and she did attain, I think she's like 12th line therapy and got into a CR and got through all of her doses of Lonca T. And so, this is, again, very impressive PFS and OS from this single institution IIT from that standpoint, and I think we'll see data continue to be generated from this patient population. What about the heme toxicities? Nothing really to talk about. I think what you see here is what we know in the relapse refractory setting with Lonca T Dex. We do see the neutropenia, anemia, and thrombocytopenia, as well as the increased AST and ALT. And I think one of the things to learn here is, just like some of the other drugs that we know, this is probably a drug, a lot of finesse, and knowing when to hold it and knowing to fold it. And with that, bye.
Thanks, Matt. Okay, let's hear our second opinion case.
As commented on previously, the antibody-drug conjugate Lonca T combined with glofitamab has demonstrated impressive early findings in diffuse large B-cell lymphoma, but both Dr. Lacasse and Dr. Sal have observed impressive results with monotherapy in select patients, beginning with a 63-year-old man cared for by Dr. Sal, who was initially diagnosed with diffuse large B-cell lymphoma in 2022 and ended up receiving 12th line treatment with Lonca T.
This man is incredible. Each time he goes through something, he comes back and says, I'm fine. This patient had received several CD19-directed therapy, including 2 CAR T-cell products and tafasitamab. We decided to give loncastuximab. And despite being in 12th line of therapy, and this was really DLBCL, again, biopsy-proven relapse, we used Lonca in this patient. We use it with a usual prophylaxis schedule, with dexamethasone before, during, and after the treatment, a little bit of Lasix, and with the usual schedule of administration of this drug. And I will say there are 2 lessons from this case. The first one is that the response was not that quick. After 2 cycles, there was a minimal response. And I wonder if when you use loncastuximab with your patient, do you experience that you have an immediate response, or is it sometime delayed? When do you start to evaluate response to this antibody-drug conjugate? This patient, despite a little bit of edema in his legs, at the beginning he tolerated quite well. I will say that after 4 or 5 cycles, he started to present with rash and, skin eruption in his back. We showed him to our derm colleagues, and they said that this was mainly not necessarily photosensitization. He thought it was still probably some allergic reaction, so he advised to use topical steroids and antihistaminic drugs, and the patient tolerated. I will say to a good surprise, in a few months, a few weeks, cycles later, this patient went into CR after 6 cycles, and we were prone to continue with this patient, his treatment. I use this kind of scheme with dexamethasone 3 days, furosemide 1 or 2 days. I obviously recommend to have sun protection. Is there anything you will add to that? Are you using any antibiotic prophylaxis with this drug?
So that's kind of an interesting case. And what he described was just the opposite of what Matt described. And I'll just say in my own experience, I found Lanka to work immediately if it's going to work. So I found his case very odd, and I have never seen anything quite like that. Anybody seen like a really slow, delayed response with Lanka?
No, the responses are typically described as being, as Matt and you described, more like cycle 2. Although I do tend to think about using this agent more similar to the way that Gilles was using it in a much later line of therapy.
So I usually will get a scan after 2 cycles. I was involved in the phase 1 studies with Matt. I feel like we learned a lot of what not to do with this drug, and if it's not working, you don't want to keep piling the drug on, because there is a cumulative risk for certain toxicities, especially the vascular injury and capillary leak that seems to occur with the third spacing, which can be very relentless and prolonged if you don't recognize it quickly. Anybody experienced rash with Lanka?
It seems like what Gilles might have been describing is the tesserine kind of hyperpigmentation that you see, because there's certainly the photosensitivity that you see, and that's why you are counseling patients, especially if you're treating them in Miami, to cover up, wear your wide brim hats and whatnot, because you will kind of get this red lobster-like approach. And what's interesting is, so I've heard, because we don't see it in Omaha. I don't know if it's a latitude thing, but it's supposed to be not painful. It's just like not like a sunburn, but it's like I don't know. And you give corticosteroids and it gets better. But I've seen described the kind of the hyperpigmenting rash, which is more of a cumulative tesserine related issue.
I have seen the photosensitivity in a kind of an extreme case where the patient came in with literally blistering, and it was painful in that. So I really do think you have to counsel patients on the sun exposure and be very careful about that.
Was that in St. Louis?
It was in St. Louis.
Okay.
It's kind of a sad story, but it's my fault, so I'll tell it. I had a very nice gentleman, probably 90. He was in an assisted living, very mild dementia, but pretty with it. Relapsed large cell. I don't know what line we're on, 4th. He wanted to try one more thing. I said, let's try Lanka. Had a son in with him. I said, hey, you got to be careful with sun exposure. Well, of course, the son takes him back to assisted living, right? And it doesn't get communicated. And I didn't think to call the assisted living. And the assisted living, bless their hearts, they put him out in the sun, so he could get some sun. And so that's why you have to be careful. That's why he got such a terrible rash, is I didn't communicate it very well. Any other toxicities that you guys have seen with Lanka that people should be aware of?
Yeah, I was just going to add that, I do think that the generalized edema, I've had, one person who had some ascites, which was also a prior manifestation of her disease. So it was very confusing. And then with the rash, there's, I think, some pruritus that comes with that as well that can impact, how patients feel. But, just to go back to the doing a scan after 2 cycles, I understand that, and I do that for people where I'm super worried. But if they are clinically improving, I'll often wait until 4 cycles.
Sure.
I don't think, a radiographic lack of response after 2 would change what I'm doing in the relapse refractory setting. And
I don't necessarily switch, but I start talking about what I'm going to do next.
Yeah.
Because if you look, the trials, the time to response was 2 doses.
Yeah. Right.
Yeah.
But Gilles' cases, it's why you come to these things, because I'll maybe rethink my.
But I do think there is really, this is a very active agent, but managing the toxicities is really important. So, the sun exposure is one, but what you mentioned, Matt, is also really important. At the beginning of when you start to see some edema, act on that right away, especially if they're responding, so they can stay on the drug and Yeah.
Yeah.
So I think there will be a learning curve.
Totally agree with that.
Yeah.
Okay, let's do our next case.
Dr. Lacase also cares for a patient who benefited from Lonca-T monotherapy, this time a woman with recurrent follicular lymphoma.
I have a patient who had a very, very aggressive follicular lymphoma, no response after CAR T cell therapy. And I treated her with loncastuximab, and it was the only therapy to which she had a complete remission. And it did actually provide her good palliation. I was impressed that even after a CD19 CAR, she had a complete metabolic remission. I really warned her about the sun exposure, and she did get this blistering rash on sun exposed areas on her hands and on her shoulder that looked really concerning. I was impressed at how well it did respond to high dose topical steroids. You really have to very seriously counsel patients about even sunlight through a car window. It's very minimal exposure can cause this really significant rash, and it's uncomfortable for patients. But I think we're going to see more of this drug, particularly if this glofitamab data plays out the way we think it will. We actually did continue to treat her after her skin improved, and it went fine in terms of the toxicity. I'd love the panel's thoughts on how to manage a patient who has progressed after or not responded to CAR T in terms of thinking about using loncastuximab, either alone or, what your thoughts are about this emerging data in combination with a bispecific antibody, i.e. glofitamab from the LOTUS-7 study.
So the patient you described had follicular lymphoma. We heard Matt has used it in follicular. I'll be honest, I was a little surprised that it made it in the NCCN guidelines off this one kind of small study, although the data is admittedly very impressive. Does anybody else have any experience with Lonca in relapsed follicular lymphoma?
Yeah, not in follicular lymphoma, but based on the data, it's something I would consider.
Yeah, same?
I haven't used it in follicular yet.
Yeah. And your experience in diffuse large B-cell lymphoma, similar to what the data shows, any pearls of wisdom?
Yeah, as I mentioned, I think about it as Gilles does, as a much later line of therapy after patients have had either an option for CAR T or been viewed to be ineligible for CAR T after bispecific antibody. I think the real challenge for me with the glofitamab combination is how to utilize that versus giving serial treatments with one if the other is ineffective. I think using it in combination while the response rates are high, I'd want to see much more durable responses and want to have some option to take those patients too. If there was an additional CAR T or an additional option for those patients, then that might be something to consider to get a better response before going into that.
One of the things I've always liked about Lonca is it's kind of patient-friendly from a schedule standpoint. Yeah. IV infusion, 30 minutes, once every 3 weeks. So if your patient's coming from like 3 hours away, it's not so much back and forth. I've always thought that was a nice thing for patients. Okay, so I'm going to jump to module 4, and we're going to talk about BTK inhibition for lymphoma. So we'll talk about BTK inhibitors in lymphoma. We have several now available. First generation ibrutinib, second generation acalabrutinib, zanubrutinib, third generation pirtobrutinib. Obviously, these have been game changers in CLL, and they're really the mainstay of therapy. I would say they have an evolving role in the management of lymphoma. So here's where we have current indications. There's no current indication in frontline large cell, follicular, or marginal zone. In mantle cell lymphoma, though, just in the last 2 years, you can give BTK inhibition as part of the ECHO regimen. You can give it as part of the Bovin regimen, which is for P53 mutated mantle cell lymphoma, or as part of the Triangle regimen, and I'll remind you of what these regimens are. Relapsed refractory is where it has a little more use, no indication yet in DLBCL, but in follicular lymphoma, we have the zanubrutinib obinutuzumab combination. In marginal zone lymphoma, there's an approval for single-agent zanubrutinib, and then in mantle cell lymphoma, really second-line therapy of choice for a number of years now has been either single-agent acalabrutinib or zanubrutinib, and if and when those fail, you can go to single-agent pirtobrutinib or go to pirtobrutinib after CAR T failure. So BTK inhibitors have been combined in frontline diffuse large B-cell lymphoma. This was the Phoenix trial where ibrutinib was added to the R-CHOP regimen. And in the top left, you see the ITT. That's the overall study. It was a negative study. Ibrutinib did not improve the outcomes for progression-free survival. But when you look at it by age, it was really this remarkable finding where ibrutinib added to R-CHOP this was in ABC, diffuse large B-cell lymphoma, did improve outcomes for progression-free survival and overall survival. But that benefit in younger patients was kind of offset by worse outcomes in older patients, mostly due to toxicities. So ibrutinib did not get a frontline indication combined with R-CHOP in ABC, diffuse large B-cell lymphoma. But learning from that experience, AstraZeneca has launched the Escalade trial, phase 3 Escalade trial, testing acalabrutinib combined with R-CHOP, a somewhat safer BTK inhibitor, and then limiting the patient population to just younger patients with untreated diffuse large B-cell lymphoma. And this trial is fully enrolled at this point, and we're just waiting for outcome data. So, we went, 25 years with R-CHOP and nothing being able to beat it, but we now have 2 trials that have been somewhat better than R-CHOP in the last 3 years, and we may have a third presented here any day now. What about follicular lymphoma? So this is the Rosewood trial. This was in relapsed follicular lymphoma patients who had had at least 2 prior lines of therapy, and they were randomized to zanubrutinib plus the anti-CD20 obinutuzumab or obinutuzumab alone. I will admit I was somewhat skeptical about this trial when I first saw it because ibrutinib had been tested in follicular, didn't work very well. Acalabrutinib had been tested in follicular, didn't work very well. Wasn't sure why zanubrutinib would work terribly well. The overall response was the primary endpoint for this study, and what you can see here is a pretty big advantage for the zanubrutinib obinutuzumab combination with an overall response rate of 70% for the 2-drug combination compared to 44% for single-agent obinutuzumab. So the trial met its primary endpoint. And you can see pretty respectable curve separation here for duration of response and progression-free survival. And there was even a borderline not statistically significant, but a trend toward improved overall survival with this regimen. Now, it is a prolonged regimen. It's 2.5 years of obinutuzumab in indefinite zanubrutinib therapy, so it is a prolonged duration of therapy. You have to know that going in, but it was definitely a positive study, improved response rates, progression-free survival for zanubrutinib obinutuzumab, and it led to an approval in relapsed refractory follicular lymphoma. What about marginal zone lymphoma? So this is the trial Magnolia that led to the approval for zanubrutinib. This was an accelerated approval. Patients with relapsed refractory marginal zone lymphoma. At the bottom, you can see broken out by marginal zone subtype. You see extranodal, nodal, and splenic. And when you combine them all together, the overall response rate for single-agent zanubrutinib was around 70%. So very impressive response rate in this relapsed population with about 25% complete responses. You can see the follow-up is not terribly long on these curves, but we're getting out to 2 and 3 years. And so you can see the progression-free survival durability is very respectable for single-agent zanubrutinib in relapsed marginal zone lymphoma. And there really were no unexpected toxicities. There was the things we're used to seeing with BTK inhibitors, like easy bruising. Some patients have a little bit of diarrhea for a while, maybe some arthralgias for a while. These things usually get better if you just hang in there and stay on the medication. And so this led to an accelerated approval in 2021, and this drug gets used a fair bit now in marginal zone lymphoma. Where BTK inhibitors are getting the most use in lymphoma is in mantle cell lymphoma. So trying to summarize it here, when we think about mantle cell lymphoma frontline management, we often think about older, less fit patients, what's appropriate for them. Probably in the U.S. and a lot of places right now, BR with R maintenance is still the standard, but we now have this positive trial called ECHO. And so adding a BTK inhibitor to that regimen is definitely a consideration. I think there's some pros and cons to that. I'll be really interested to hear what the panel thinks about that strategy in older patients. When you have younger fit patients, we have this landmark triangle study, which shows that the addition of a BTK inhibitor allows you to subtract an autologous stem cell transplant from the regimen. That's a big win for patients. And then for this very difficult problem of p53 mutated mantle cell lymphoma, where chemotherapy doesn't work very well, we're learning that all targeted agent regimens, really extrapolating from the CLL experience, are showing more activity. So we have this regimen now called Bovin, which I'll show you in a little more detail. Relapsed disease, we have single agent ACAL and Xanu available, and those are mainstays. We have the third generation BTK inhibitor, pirtobrutinib, and of course we have CAR-T. So this is the ECHO trial. This was for patients 65 and above with untreated mantle cell lymphoma. The control arm is bendamustine rituximab for 6 cycles, followed by 2 years of maintenance rituximab. So a good solid control arm in this trial. The experimental arm, same backbone, but then add acalabrutinib, 100 milligrams PO/BID throughout the induction, through the 2 years of maintenance, and then continuing the acalabrutinib until disease progression or unacceptable toxicity. Primary endpoint of this trial is progression-free survival. And you can see in the analysis in the upper left, there was a progression-free survival benefit for adding acalabrutinib to the BR regimen. If you look right below it in panel C, the overall survival curve, there is not an overall survival benefit. It turns out that there were definitely better disease control with the ACAL added. There were less mantle cell lymphoma deaths, but there were more infectious deaths in the patients where ACAL was added, and a lot of these were COVID deaths. This enrolled really during the height of the COVID pandemic, and so they did a reanalysis with the COVID death censored, and you can see the curve separation for progression-free survival gets even a little higher. So what do you do with this result? No difference in overall survival. It definitely controls the disease better, but maybe increased infectious risk. This is a similar result to what we saw with SHINE, which had tested ibrutinib. So based on this study, acalabrutinib has now been approved for older mantle cell in first line in 2025. Should you use it? You get a progression-free survival benefit without an overall survival benefit. My one reservation is you are using up your covalent BTK inhibitor in the first line, meaning you won't have it available in second line. So it sort of comes down to a sequencing question. Do you want to use it early or do you want to save it for later? I'm tend to save it for later, but I'd be really curious to see what my panel members say about that. Now, there is a big effort in mantle cell lymphoma to try to get to chemo-free using BTK inhibitors as the anchor. This was a trial done in Europe called ENRICH, where a combination of rituximab and ibrutinib was compared to immunochemotherapy strategy based upon the site's choice. It could be bendamustine rituximab or R-CHOP, followed by 2 years of maintenance rituximab. And when the trial was presented at ASH, it was billed as a positive study for immunochemotherapy. That's the top curve on the left. Ibrutinib rituximab was better for progression-free survival. If you look at the bottom, however, all the benefit came from the comparison against R-CHOP, which isn't terribly effective in mantle cell lymphoma. And when you compare the ibrutinib rituximab against BR, that's the bottom right, then you don't have the same benefit. So I didn't really see ENRICH knocking BR and our maintenance off the standard of care block, but I just want to make sure you're aware of that trial. Now, that's a doublet where the main efforts have been the last few years are these chemo-free triplets built around BTK inhibition. So we have this trial of acalabrutinib, lenalidomide, rituximab that's been reported. Very active, a lot of rash. Probably not the best combination going forward because I think we have these other combinations that look a little more promising. So number 2 there, this acalabrutinib, venetoclax, rituximab combination. This was presented at ASH 6 months ago. 108 patients, overall response rate 95%, CR rate 86%, Very short follow-up, but at 12 months looking highly promising. So really good data for a chemo-free triplet. And then this bovine regimen, which was first published in the P53 mutant mantle cell lymphoma patients. This was presented at ASH as well for older mantle cell patients. Zanubrutinib, venetoclax, obinutuzumab, older mantle cell patients, very high response rate, very high complete response rate, very impressive 2-year PFS. So these chemo-free triplets appear to be ready to move into the future. What's more immediately available are a couple of trials that should read out sooner. On the left, you see the schema for this trial called Mangrove. It's using BR as a control. No maintenance, though, so a little bit of a weaker control than I'd like to see. But it's using zanubrutinib rituximab as the experimental arm. This trial is fully enrolled and should read out relatively soon. And on the right, you see the schema of a U.S. cooperative group trial, assuming that zanubrutinib rituximab was going to win and become a new reasonable standard in older mantle cell patients. And this is a really interesting trial looking at, okay, you do your zanu rituximab for 6 months, you get reassessed. If you're in a complete remission, you're then randomized. And you're randomized to stay on zanubrutinib or take a therapy break. And if you take a therapy break and then progress later, you get to go back on your zanubrutinib, still on the study, and it's really being progression-free survival 2 is being compared against progression-free survival 1 for the people taking continuous zanubrutinib, really asking the question, can we give people breaks from their BTK inhibition without paying a penalty? This was a trial that really moved the needle in younger mantle cell lymphoma, the Triangle trial, using the European standard, R-CHOP, RDHAP, and autotransplant. That had been the standard for a number of years. And what they did in this trial is they added the BTK inhibitor ibrutinib. So in the second arm, ibrutinib is added to the induction, and then added as 2 years of maintenance following stem cell transplant. And then there's a really interesting third arm at the bottom, where ibrutinib is added during induction and as maintenance, and the stem cell transplant is subtracted. So this has been published, and we now have updated results. And really the bottom line is the 2 arms that contained ibrutinib did much better. The upper curve on the left compares autotransplant plus ibrutinib against autotransplant. The inclusion of ibrutinib was better. The curve on the upper, that's the upper left, the curve on the upper right compares autotransplant versus ibrutinib. You can see curve separation favoring ibrutinib. And then if you compare the 2 ibrutinib-containing arms at the bottom, they're pretty much superimposable. So if you do autotransplant and ibrutinib, your 4-year failure-free survival is 82%. If you do just ibrutinib, it's 81%. So you probably don't need to include that autotransplant to try to move from 81 to 82% at 4 years. There's the overall survival curves, and we're starting to see some emergence of an overall survival difference for the ibrutinib-containing arms as well. So that's really become a new standard. The addition of the BTK seems to obviate the need for autologous stem cell transplant in frontline mantle cell lymphoma. Now, ibrutinib was pulled from the U.S. market a couple of years ago, but according to the NCCN guidelines, you can substitute acalabrutinib or zanubrutinib, which I'm perfectly comfortable doing. And one of the really nice things about the Triangle strategy, unlike the ECHO strategy, is the BTK exposure is time limited. So you get to stop your therapy, your patient gets to take a break from therapy, and you've not exhausted your BTK inhibitor in the front line. And this kind of approach has really become the new standard for younger, fit mantle cell lymphoma patients. A couple of ongoing questions from Triangle. A nuance that I didn't get into, but about half the patients received maintenance rituximab and half did not on that trial, depending on what country they enrolled in. There has been a reanalysis, and it shows that maintenance rituximab adds additional benefit to the BTK inhibitor. So bottom line is you should do both if your patient is willing to do both. Are there still subgroups who might benefit from transplant? We're not sure. What if you're in a PR after induction? What if you're MRD positive after induction? These are all things that need to be looked at a little bit more and are unclear at this time. And I think a really interesting question is going forward is, do we still need to give the high-dose cytarabine? if adding the BTK inhibitor allows you to get rid of the stem cell transplant, I think it's reasonable to think adding the BTK inhibitor allows you to get rid of the cytarabine. And we did a cooperative group study that was just been submitted for publication that suggests that you actually can subtract the high-dose cytarabine. So this is the next U.S. cooperative group trial that will be initiated hopefully in this next year. Untreated younger patients with mantle cell lymphoma will start on zanubrutinib. They'll have a mutational testing for P53 mutations, and if they do, they sort of go down to the bottom of that curve, where they'll do a bovin-type regimen, zanubrutinib, sonrotoclax, obinutuzumab, then with a randomization to continue on novel agents versus trying a glofitamab consolidation. That'll only be about 10 or 15% of the patient population. The meat of the study is up above, and our control regimen is going to be BR, no cytarabine, for 6 cycles with zanubrutinib, followed by 2 years of maintenance rituximab, 2 years of maintenance zanubrutinib, compared against a chemo-free approach of zanubrutinib, sonrotoclax, obinutuzumab, with the same 2.5-year total duration of therapy. So we're excited about this trial and hope to have that available soon. I'll just finish up with 2 slides. P53 mutated mantle cell lymphoma, a huge problem in our clinics, and this all novel agent regimen looks very promising. Zanubrutinib, obinutuzumab, venetoclax, response rates north of 90%, and about 3/4 of patients progression-free at 2 years, which is better data than we've seen in this high-risk population. And then don't forget about pirtobrutinib, the 3rd-generation BTK inhibitor. This trial is fully enrolled. It was pirtobrutinib versus investigator's choice of ibrutinib, acalabrutinib, zanubrutinib, and it was designed as a superiority trial to see if pirtobrutinib can produce even better efficacy than 1st and 2nd-generation BTK inhibitors. Trial is fully enrolled, and we're just waiting for results at this point. And with that, I'll stop, and let's go ahead and hear about our next case.
In the last few years, the upfront management of mantle cell lymphoma has shifted dramatically away from chemotherapy to novel agents, and Dr. Lacaze has a challenging case in this regard.
It's one of my favorite patients. He's a 98-year-old patient. We could have thought about using standard bendamustine plus rituximab, but he was really keen to try a novel agent, so I put him on single-agent acalabrutinib, and he achieved a metabolic complete remission by PET scan relatively quickly. Of note, this patient also has atrial fibrillation and is on anticoagulation with apixaban. So from the panel, I think we see a lot of these elderly patients with mantle cell lymphoma, and would love to hear thoughts about initial therapy, particularly now in this day and age. Would you use single agent BTK, or would you combine it with a CD20 antibody? Would you do something different? And thoughts also about patients on anticoagulation. I think that's always something I worry about a little bit in these elderly patients who may be more susceptible to falls. In this patient, at that time, I chose acalabrutinib. I'd love to hear the panel's thoughts on what their go-to frontline agent would be if using a single-agent BTK inhibitor.
Okay, how about if we start with Chris? You get an elderly, let's say they're 86 years old, mantle cell lymphoma, in need of treatment. What kind of approach are you thinking of for that person?
Yeah, well, thanks for not giving me the 98-year-old that Ann was treating. So we very commonly give BTK inhibitors or chemotherapy-free regimens as the first-line therapy in our center, and that typically either would be acalabrutinib with a CD20 antibody, typically rituximab, or zanubrutinib with rituximab for that patient population. I think, the atrial fibrillation with those 2 agents no longer gives me the same kind of pause that we used to have with using a ibrutinib in the first line, and somebody who has well-controlled atrial fibrillation is being managed on anticoagulation and that atrial fibrillation is controlled, I think is something that you can monitor safely with those drugs.
Yeah, agreed. Matt, how do you think about the anticoagulation issue when you're starting a BTK inhibitor? You have someone who's on Eliquis for whatever reason.
I don't. don't give me much pause anymore, similar to Chris's response. I think sometimes, though, the platelets are a little bit lower if there's significant bone marrow involvement as you get into further and further, mantle cell lymphoma. Also, those patients that often have the leukemic disease or have massive spleens, they are the ones that give me a little bit, because their platelets are quite a bit lower at the time of diagnosis from that standpoint. And in regards to in regards to atrial fibrillation, not all AFib is created equally. There's some people who go into AFib and go to the ER, and then there's obviously odds that one of us in the room right now is in atrial fibrillation. We don't even know it. Our watches will tell us, but anyways, and so there's two different kinds, and I think both of them can be seen with the BTK inhibitor.
Sony, let's think about follicular lymphoma and this zanubrutinib obinutuzumab combination. Think about lines of therapy in follicular lymphoma, and where do you see this combo kind of fitting in?
Yeah, that's a really good question. I think just like you, I was super surprised that this was a positive study, pleasantly surprised, I should say, because we'd had so many negative trials with ibrutinib. I think I would consider it second line or third line for some patients, who are trying to minimize their infusions, that's an option for them. I think the challenge I have is that the zanubrutinib is given, for a very prolonged period. I mean, it's indefinite after that. So that's really the hardest part of that regimen for me. But I think it has a role for some patients who, prefer not to come in after a certain amount of time when the obinutuzumab is done.
Yeah. So we have some questions from the audience. I might do rapid fire down the line here.
Okay.
Matt, I'm going to start with you.
Let's do it.
This is classic Neil Love. He probably typed this one in for us. Regulatory and reimbursement issues aside, which third-line therapy would you generally recommend for a 65-year-old patient with diffuse large B-cell lymphoma who received first-line POLA-R-CHP, subsequently experienced disease progression after second-line CAR T-cell therapy? So,
how quickly?
We don't have that detail.
Okay.
Let's assume the CAR T remission lasted 1 year.
If they're young and fit, and I'm trying to get them to an allo transplant, then I'm going to try and get them Glow-Fit. I think that's the strongest data right now if I'm looking to bridge. It's also a fixed duration therapy, and regulatory and all that stuff is out the window, so I can get access to it. I've seen it work. It'd be tolerated.
Sony, question for you.
Yeah, this is a really hard one. I mean, currently I would use a bispecific agent as a monotherapy, but obviously all these combinations are coming out. So, I'm impressed by the Glow-Fit Lonca data, but it is still very limited data. So
Right.
I don't know if I can say that I jump on that train with the same amount of enthusiasm. Yeah.
Yeah, like Sony, I would most commonly give a bispecific antibody. It depends on, as a single agent, it depends on how frail the patient is, which of those I would choose. But I think the strongest data currently are the randomized data of Mosun Pola, which is what I would think about depending on how long it's been since polatuzumab was used the first time.
Mosun Pola, got it. Chris, do you envision CAR T-cell therapy or bispecific antibodies becoming a standard component of first-line therapy for patients with DLBCL in the next few years?
Yeah, well, we've got intriguing data that will be coming out on the earlier use of CAR T-cell for patients who have evidence of cell-free DNA that is positive after first-line therapy, and I think that will be the thing that gives us kind of the equivalent of utilizing that in more of the first-line setting as it moves forward. I think the other thing that we will see in the coming years, now this will come first in the later lines of therapy, are the in vivo CARs, and I think those could be more rapidly moving up in lines of therapy because they will be easier to use across patient populations. As Sonny alluded to, I think even if we had access to CAR T-cell in the first line, there would be limited numbers of patients who would actually get that.
I'm not ready to go to CAR T for all just yet. I don't think it's going to happen in the next few years, maybe down the road as we learn a little bit more, because, CAR T, as much as it's a one and done treatment, there are persistent cytopenias, a lot of lymphopenia, a lot of infections. And, it's not, it's like the gift that lingers, right? And so I don't think we're ready to move it up front. Maybe for a very small percent of patients with high risk features, positive MRD after 2 cycles of an anthracycline-based regimen, dark zone signature, things like that.
Matt, what about bispecifics? We have 2 trials out there. We have epcoritamab added to R-CHOP, and we have glofitamab added to R-CHOP-POLA that should read out at some point. Are you expecting positivity from those studies?
I'm expecting positivity in regards to efficacy. I think what's the untold story will probably be of that escapade is at what cost toxicity-wise, because I am concerned about, we've seen what happens with single agent bispecifics in regards to infection risk. Also thinking about, when you combine with chemotherapy. Now moving into the front line, I think it'll be a positive trial, but the toxicity will be the tail of the tape. I do think that cell of origin probably goes out the window with bispecifics, at least when you look at the Dana-Farber as well as the Coalition Australian data. Both of them showed both ABC and GCBs doing very well against small patient subsets, but it would be nice to, and all the science is cute, but if we just can get rid of it and then everybody has access to it regardless of cell of origin.
Maybe just one comment there. So I agree that perhaps cell of origin goes out the window. The one thing to point out from Andrew Harkin's data that he presented, about a third of patients at diagnosis in Polarix had an exhausted T-cell phenotype. And so that may be the new new signature that predicts what patients won't respond to therapy.
And where can you get that done at?
At a site coming near you.
So we do have a question from the audience about if you're choosing a BTK inhibitor for whatever situation, what are the comorbidities that you look for that might lean you towards one or the other? Like, it's probably down to ACAL or XANU in most of these situations. So
when I do my physical exam, and if there's like this large thing that's over their heart called an ICD,
yes,
I usually don't like BTK inhibitors in that patient population.
Understood. If you're choosing, though, between BTK inhibitors.
Do you have a coin?
I can opine. I know. Yeah. It's like, what side did you pick up on? If your patient has a migraine history, I can tell you ACAL is probably not going to go well.
Yeah.
If they have difficult hypertension, I would probably avoid XANU and lean toward ACAL because there's definitely some hypertension with XANU that can occur. I don't know if anybody has any other things that they look for.
I think those are all great suggestions. I think more commonly when a patient walks through the door, it is more, as Matt said, a little bit of a toss of a coin about where you're thinking about going between those 2 combinations.
Yeah, there is a poster, that's retrospective looking at, relative efficacy of the different BTK inhibitors. I hesitate to use that to drive decision-making. I think it really ends up being something you talk about with the patient, and sometimes their insurance determines, what you go with.
Yeah.
I want to thank our panelists, our online audience, our live audience for a great discussion today. I hope you all enjoy the rest of your ASCO, and thank you very much.